Okay, good morning, class. Welcome to our new topic on antibiotics. And we shall get started by looking at this introduction to antibiotic as our first unit for today. Uh, First of all, we look at medications that are used to treat bacterial infections. So basically, what happens is that antibiotics are the medications that we use to treat a bacterial infection. This terminology is used for those category of medications. Uh, when we look at the types of infections that these drugs are used to treat, we have the community-associated infections, and we also have the health care-associated infections, sometimes called nosocomial or hospital-acquired infections. Let's look at antibiotic therapy types. There's what we call empiric therapy. This is a treatment of infection without specific culture information. For example, a patient is brought presenting with signs typical of meningitis, maybe stiff neck and all the rest. And this happens in a remote health facility where you don't have the capacity to do culture sensitivity. You don't need to wait and maybe do some laboratory investigation, but the best you can do here is immediately basing on your clinical suspicion to start this person on treatment that that is intended for meningitis. If it's an adult, we can start with ceftriaxone using the meningitis dose. So this is called empiric therapy, giving treatment just like blind cover. We call it sometimes blind treatment. Okay, and most times it's used like broad spectrum, extended spectrum antibiotic because you really don't know specifically which bacteria we are dealing with. So we have to use empiric therapy. Definitive therapy is tailored antibiotics treatment based on identified organisms from cultures. Okay, so here, in definitive is the opposite of empiric. Here, first of all, somebody gets sick, we get samples, take it to a culture and sensitivity laboratory, and then they'll definitely tell us exactly what bacteria might have caused that specific infection. It could be a bacteria, it could be whatever. But for this case, with antibiotics, this antibacterial, it will tell us the bacteria that we are dealing with that is causing this particular infection, and we shall just use the specific drug that that is used to treat this particular bacteria infection. Prophylactic therapy, prophylaxis, this is something given like a preventive way of treatment. Okay, so you're giving a drug to prevent the occurrence of an infection in an individual. These antibiotic treatments to prevent infection commonly used in surgeries or trauma. So, for example, someone who is undergoing surgery can be given an antibiotic cover because we anticipate infections might happen because of the procedure. Somebody also has had trauma might still be given prophylactic treatment. Let's look at antibiotic therapy. Uh, we said therapeutic response refers to the improvement in signs and symptoms that the person has acquired after being given a treatment. So the improvement that he gets from the infection is what we call the therapeutic response, how quick the person is responding to the treatment, okay? Or how slow. Example for include fever. Okay, somebody has fever and is given maybe an antibiotic, and then the fever goes down. We can look at therapeutic response, maybe with regard to the time response also. The white blood cell counts, okay, erythema, inflammation, drainage, or even pain. Okay, so maybe somebody has very severe pain, and then we give those analgesics, and then we also see therapeutic response. How long does it take for this person to be healed from from this pain, or how long does it take for this pain really to subside, or how quick does this happen? Therapeutic response is like a lack of the intended improvement. Okay, in the signs and symptoms. Perhaps we only get maybe a minimal response, minimal improvement despite giving the treatment. This is subtherapeutic as compared to therapeutic response. So for infection, refers to secondary infections such as fungal yeast infections. Okay, yeast is a fungi, of course, due to disruption of normal flora. So sometimes what happens is that when the normal flora are disrupted, it predisposes the individual to infection by secondary other infections. So the normal flora refers to those bacteria that normally resides as part of our uh, no comments are normal body systems. For example, we have bacteria that reside in the gut, and if we give someone quite some extended spectrum antibiotics, sometimes it end up altering the normal flora, and this perhaps also causing infection and also colonization by other secondary infections like the yeast. Let's look at complications and considerations of antibiotic therapy. We said resistance development due to overprescribing antibiotics. This is a very big topic and is really questionable that we need to always watch our prescribing behaviors in regards to antibiotics. Misuse of antibiotics really need to be uh, prohibited. Otherwise, most of the drugs become ineffective because of uh, bacteria becoming resistant to them. Food and drug interactions. We looked at introduction. We looked at how food and drug interactions may also affect um, medications. We also look at patient-related factors affecting antibiotic response, including allergies, pregnancy, and also organ function. Okay, we talked about renal clearance of certain drugs, so all those need to be considered. For pregnancy, we also have drugs that are teratogenic. Okay, so we need to see is this drug worth it to give in someone who is pregnant, or you have to give an alternative because this one is contraindicated. Severe reactions to antibiotics like penicillin sulfonylurea, we talked about adverse reactions, and we said almost 5% of the population is always allergic to penicillins in the sulfur drugs. Okay, so we need to take also note of this kind of complications in antibiotic therapy. Also, substance harmful to the developing fetus. Okay, we talked about teratogenicity in the fetus. Uh, they are not supposed to be used in pregnant women, so we need to look at which among those antibiotics fall in all these categories so that we prescribe it for some. Complications and consideration of antibiotics continuing. We also look at genetic conditions influencing antibiotic metabolism and response. So these variations also manifest differently and affects the way antibiotics also work in different in individuals. Anatomic site of the infection. This also plays a role because we said normally areas that are well are supplied with blood vessels heal faster. Okay, so if there's an infection in areas that are highly vascularized, it's obvious that the healing process may take a bit faster than areas which diminished blood supply or minimal blood supply. Uh, Determines choice, dosage, route, and duration of antibiotic therapy. So all this is what we do for every drug. Okay, some drugs are given IM, others are given IV, others are given 2 times a day, 3 times a day, or even 4 times. Others are given once a day. So all this is about the duration, the route, the dosage. We need to follow all those uh, kind of guidelines. Let's look at the mechanism of action of these drugs, the so-called antibiotics. We said the antibiotics kills bacteria through the bactericidal action. Some of bactericidal means it kills the bacteria directly. Okay, it kills the bacteria directly. Example of these drugs that has bactericidal action are all the penicillins. Okay, the narrow spectrum, the extended spectrum, or the broad spectrum penicillins, all of them are bactericidal. We also have the cephalosporins. The commonest example I can give here is the third generation cephalosporin, ceftriaxone, which most of you are very familiar with. I can say that it is currently highly abused in Juba in terms of prescribing behaviors, because honestly, I'm saying we are not going the right way because the control is not to the expected standard, especially even including in the over-the-counter outlets. We have fluoroquinolones. Example here is the ciprofloxacin and the other groups. So all these have bactericidal action. They result in irreversible damage to the bacterial cell walls or intercellular structures leading to bacteria. So this is how it kills the bacteria. Okay, uh, it breaks the bacterial cell wall, and then it causes an irreversible damage, and then bacteria dies. That mechanism. They are often preferred in severe infections or immunocompromised patients. So these drugs are supposed to be used really when an infection is severe or immunocompromised patients. Let's look at the second group, the bacteriostatic drugs, bacteriostatic action. Okay, these ones, they inhibit the growth and production of the bacteria. So what they do is they don't kill the bacteria like the bactericidal medications, but here they just inhibit the growth of the and reproduction of bacteria. So therefore, thereby limiting their expansion. Does not directly kill bacteria but prevents their proliferation, allowing the immune system to eliminate. So what happens is if the bacterial growth has been halted, and then later on the body system comes and get rid of the bacteria because they will not be multiplying in a faster number, and the immune system of the body will be able to get rid of them. The examples of these drugs, we have the category of the macrolides, tetracyclines, and the sulfonamides. We shall see more about macrolides and tetracycline in the upcoming lectures. They may be sufficient for mild to moderate infections or in combination therapy with also the bactericidal agents. Sometimes they can be combined. Now, let's look at selective toxicity. Selective toxicity is a fundamental principle of antimicrobial therapy, referring to a drug's ability to harm or inhibit the growth of invading microscope while causing minimal harm to the host cells. What is the point here? So all these drugs, these antibiotics, works on the principle of selective toxicity, meaning that the principle of action of this strategy is that the drug will be able to selectively kill the, the, the microbial agent that we are targeting to kill, but at the same time while sparing the host, while sparing the individual. Okay, so this drug will kill the bacterial cells, but it should not kill your cells. But of course, if any, it should just be a minimal harm to the host cell. So that's how it still have the side effects and the adverse reactions that happens, but the target is that we need to get rid of uh, the, the microorganism. So that is what we call selective toxicity principle. This characteristic is crucial for effective treatment while minimizing the adverse effects. Now, let's look at the spectrum of activity or the spectrum of action of those antimicrobial medications. We have the narrow spectrum antibiotics. We also have the broad spectrum antibiotics. The narrow spectrum antibiotics target a limited range of microorganisms. Okay, so one drug can target a range of certain microorganisms, but not a greater capacity or typically specific bacterial species or strain. They are often preferred when the causative agent of the infection is known or when there is a need to spare normal flora. So here, for example, where we have better facilities like we have culture and sensitivity, and already we know really every infection that a person has, we are able to do the culture and study the bacteria that causes that. We can give specific treatment in this case because we already know that bacteria needs this particular drug. The broad spectrum antibiotic, these agents are effective against a wide range of microorganisms, including both gram-positive and gram-negative bacteria. So this one, what you need to know about broad spectrum is that it kills both gram-positive and the gram-negative bacteria. While they offer a broad coverage, they may also contribute to developing antibiotic resistance. So this is a problem, antibiotic resistance, because we are just blind treatment, and might also disrupt the body's natural microbiota. So once the natural microbiota, which is the normal or the bacteria that resides with us in the gut is disrupted, it also causes infections. Antibiotic resistance, very, very important concept really to undertake. Antibiotic resistance poses a significant threat to public health as it reduces the effectiveness of the available treatment and increases the risk of treatment failure, prolonged illness, and mortality. So, what happens with antibiotic resistance is that the microorganisms or the bacteria that we're talking about tend to develop some mechanisms to resist the action of the drugs that we use to treating them. So that means in the long run, the same drug that used to treat this bacteria, well, used to kill this bacteria, will become less effective in killing the same bacteria. So at the end, it's just wasting our efforts of manufacturing the same drug and it's no longer working. So this is a serious, serious, serious threat in evolution. And there are risk factors that leads to this, and we are supposed to minimize, to make sure those risk factors are minimized so that really we are not at the threat of antibiotic resistance. Bacteria can develop resistance through various mechanisms, including genetic mutations. So this is what the bacteria does. When a mutation happens, remember our mechanism of action. Some of them acts at this level, and when the gene mutates, that means already it brings a resistance to a drug that was initially active to the same bacteria. Okay, horizontal gene transfer like conjugation or even enzymatic inactivation of antibiotics. Some of these antibiotics work on bacterial enzymes, okay? But then when once they're inactivated, it becomes resistant. Still looking at gene mutation, we said bacteria can adapt and evolve in response to environmental pressures, including antibiotic exposure. Genetic mutations can occur spontaneously within bacterial populations, leading to changes in their DNA. Therefore, these mutations may affect genes involved in antibiotic targets, such as those encoding proteins essential for bacterial cell wall synthesis or the DNA replication. As a result, bacteria with mutated genes may become resistant to the effects of certain antibiotics, rendering them ineffective in inhibiting bacterial growth or killing the bacteria. Let's look at the horizontal gene transfer mechanism as a way of bacterial resistance to antibiotics. Here, bacteria can acquire resistant genes from other bacteria through horizontal gene transfer. One common mechanism of this gene transfer is conjugation, where a genetic material, including genes encoding antibiotic resistance, is transferred directly from one bacteria to another through physical contact. So remember, you might see some of these pictures in your microbiology where bacterial conjugation, two bacteria can come together and then a conjugation occurs where a genetic material is inserted into the other bacteria. So if this conjugation occurs from a bacterial strain that's already having this resistant strain, and then is conjugated to the other bacteria, already it is a way of transmitting a strain that is resistant to the drugs that are already known. It is transferred directly from one bacteria to another through physical contact. This transfer often occurs by what we call the plasmids. It's really one of the common challenges currently to bacteria, to antibiotic resistance. Okay, and then small circular DNA molecules that can replicate independently of bacterial chromosomes. So plasmid, by definition, these are small circular molecules that replicate independently of bacterial chromosomes. So plasmid containing resistant genes can spread rapidly among bacterial population, contributing to the dissemination of antibiotic resistance. Let's look at the third step, the enzymatic inactivation of antibiotics. So some bacteria produce enzymes capable of modifying and degrading antibiotics, rendering them inactive. For example, we have the beta-lactamase enzymes. They can hydrolyze the beta-lactam ring, which is a common structural feature in many antibiotics, such as the penicillin and cephalosporins. The enzyme beta-lactamase inactivation prevents these antibiotics from binding to their target sites and exerting the antimicrobial effects. Bacteria that produce the beta-lactamase enzymes are resistant to the action of the beta-lactam antibiotics, leading to treatment failures. So we shall see more later on how the drug evolution has managed to deal with this beta lactamase producing enzymes, especially when you talk about the combinations of uh, amoxicillin and the clavulanic acid, which is clavulanic acid is a very good counter against the beta lactamase enzymes, and that's why we had the amoxicillin as a drug, because otherwise amoxicillin alone was not producing the effects needed, and then because of the clavulanic acid combination, it became more effective in overcoming this problem of the beta lactamase producing bacteria. Reduction of drug concentration at the site of action. Some microbes can stop actively taking up certain drugs. For instance, bacteria may downregulate or modify their transport proteins, reducing the intake of drugs like tetracycline and gentamicin. So in this mechanism, what happens is that uh, when a person is administered a drug and then this drug is circulating and then fixing the bacterial site, this drug is supposed to enter into the bacterial cell. What this bacteria does, it develops a mechanism. It modify or downregulate their transport protein. So the transport protein that is supposed to bring in the drug, instead they modify it so that the drug exits the bacterial body in a faster way without really causing more the bactericidal effect or the bacteriostatic effect in the bacteria, and at the end the bacteria survives and never dies from the effect of the drug. Okay, examples of drugs that have been bacteria have shown some this kind of activity towards them are the tetracycline and also gentamicin. Increasing active transport, so microbes can enhance the active export of drugs out of their cells. Okay, this is another mechanism. So they can either stop taking actively or they can increase the exports. Okay, so drug not taken in the first example, then the second example, the active transport, drug is quickly taken out. It enters the body, but it's quickly taken out, and therefore making the bacteria survive. These are achieved by upregulating efflux farms, which activate the farm drugs out of the cell. Still, we have fluoroquinolones also mentioned here, tetracycline, and also the macrolides. Another mechanism is the alternation of drug target molecules. So antibiotics, like other drugs, exert their effects by interacting with specific target molecules such as receptors or the enzymes. If the structure of this target molecule is altered, the antibiotic may no longer be able to bind effectively, leading to the resistance. Example, in this case, some bacteria develop resistance to streptomycin by undergoing structural changes in their ribosomes. We remember that streptomycin, once administered, it acts through the bacteria by binding to what we call the ribosomes in the cell. So the target sites where streptomycin acts to inhibit protein synthesis is the ribosome. So this is how actually it acts. It binds the ribosomes and prevents the bacteria from synthesizing more proteins. These alterations prevent the streptomycin from binding and inhibiting the protein synthesis. So what happens is that when an alternation happens, this drug will not work because the inhibition will fail, and then the bacteria proceeds with producing more of its proteins, and that means replicating, and the effect of the drug will not be felt. Another strategy is what we call antagonist production. So in rare cases, microbes can produce compounds that counteract the actions of other drugs. Antagonism, we looked about it. The antagonist is counteracting the action of the other. So this mechanism involves synthesis of molecules that directly interfere with or neutralize the effects of the drug. Let's look at an example. Some bacteria have developed resistance to sulfonamide, those sulfur drugs, by synthesizing increased quantities of para-aminobenzoic acid, the so-called FABA. This compound FABA competes with the sulfonamides for binding sites, thus reducing their effectiveness. So last time we said we looked at the competitive and the non-competitive binding of drugs at the receptor sites. So for the sulfur drugs to work, they have to bind to specific receptors. What these bacteria do is they produce this kind of amino acid called the PABA, which actually goes and binds to the receptors that the sulfonamide is supposed to bind to. So if this happens, then the sulfonamides will have nowhere to bind on the bacterial side, and it will have less or almost no effect on the bacteria, and then the bacteria becomes resistant to these sulfur drugs. Preventing resistance is strategies in hospital settings. So how do we prevent resistance? Antibiotic resistance, we need to have strategies starting right at the hospital setting, but also it goes beyond the hospital setting. We need effective infection control measures, timely diagnosis, and appropriate treatment of infections, and the judicious use of antibiotics guided by microbial susceptibility testing and implementation of protocols that prevent the transmission of resistant organisms. Sometimes it sounds as easy as it is, but it might not be as easy as it is to implement, especially when we start to talk about judicious use of antibiotics guided by microbial susceptibility testing in contexts like in South Sudan, for example. Let's look at agricultural uses of antibiotics. The widespread use of antibiotics in agriculture, particularly in livestock farming for growth promotion and disease prevention, contributes to the emergence and spread of antibiotic resistant bacteria. This is a practical uh, experience I saw. I saw this in Juba where somebody came all the way from the rural and then was buying quite a lot of tetracycline because they already knew. I think it had been a long-term practice where they give tetracycline to the goats they have at home, and even perhaps the cows. As they perceive they are treating certain infections, but it's really non-specific. This because of the challenge of the one health problem we have, and this kind of uh, prescribing behaviors happening, and also antibiotics given over the counter. We see this is where really we always get it wrong here, especially in Juba. The implication is that addressing antibiotic use in food production is crucial for mitigating the spread of resistance, and protecting public health. Let's look at the importance of identification and sensitivity testing. Uh, Properly identify the infecting organism and determine its antibiotic sensitivity profile through laboratory testing. This information guides clinicians in selecting the most appropriate antibiotic therapy, optimizing treatment outcomes, and minimizing the growing of resistance. Accurate identification and sensitivity testing are crucial for successful antimicrobial therapy, especially in severe or resistant infections. Let's look at what we call the minimum inhibitory concentration, which is MIC. The MIC represents the lowest concentration of the antibiotic that effectively inhibits the visible growth of the bacteria in a given culture medium. So it's trying to look at concentrations of the drugs, okay, in uh, uh, the drug that is able to inhibit the growth of bacteria in a given culture medium. This concentration is determined through laboratory testing and helps clinicians gauge the potency of the antibiotic against the specific bacterial strain that causes an infection. The next is what we call the minimum bactericidal concentration, MBC. This is the lowest concentration of antibiotic that reduces the number of viable bacterial colonies by 99.9% compared to the initial inoculum. This measurement is critical in assessing the bactericidal activity of antibiotics and guiding treatment decisions, especially in severe infections where complete eradication of a pathogen is crucial for patient recovery. Now let's look at the role of the host defenses. How do they respond to this infection? The immune response helps recognize and neutralize pathogens, while phagocytic cells such as the macrophages and the neutrophils, that are our white blood cells, engulf and destroy the bacteria. Effective antimicrobial therapy often relies on the synergy between antibiotics and the host defenses to eradicate the bacterial infections. Therefore, maintaining optimal immune function is essential for successful treatment outcomes. So the point here is like this: we get an infection, we take drugs, but then our immunity plays a role. So when we get an infection and then we take a drug and our immunity is highly boosted, you are in good health, it is easy for this bacteria to be removed. It is quickly eradicated. This might not be the case for somebody who became sick and at the same time is on medication and is even immune. This person will always take long to recover from this because the immunity is one of the best things that determines how quick we can fight these microorganisms in addition even to the treatment that we take. Completing antibiotic course. This ensures that an adequate concentration of the antibiotic is maintained in the body over the entire period, effectively eradicating the bacterial infection and preventing the development of antibiotic resistance. So this is a common problem. Many a times we are prescribed antibiotics for an infection, and then they say take this treatment for 5 days or maybe for 7 days, or maybe once a day or 2 times a day or 3 times a day. Many a times we take this day one, day two, day three, we are feeling okay. We start to leave these drugs and keep them in the cupboard. By doing this, we are already even contributing to antibiotic resistance. And this becomes a problem. We are supposed to complete all the course of this medication, otherwise, it becomes ineffective. We are ineffective is encouraging a lot of antibiotic resistance. At the same time, even you might still become sick because you have not finished your dosage. So all these are things that should be followed right from the hospital, but even also the instructions that are given for this person at home need to be followed at home for adherence to this to be able to meet this particular target. So even if symptoms improve, premature discontinuation of antibiotics may lead to incomplete eradication of bacteria, increasing the risk for recurrence of persistent infection. Therefore, patients should adhere to the prescribed antibiotic regimen and not stop treatment prematurely without consulting their healthcare provider. Combination antibiotic therapy. We said while a single antibiotic therapy is often preferred to minimize the risk of side effects and also development resistance, sometimes there's a situation where we have to combine antibiotics to get a maximum benefit, or just because to be able to eradicate certain infections that are life-threatening. Okay, this we can do this when we are dealing with a severe or life-threatening infection requiring a broad-spectrum coverage for polymicrobial infection involving multiple pathogens with different susceptibilities. We have seen this in the case of tuberculosis. Okay, we have almost four combinations. We have up to four combinations combined in one, just because otherwise already the bacteria becomes resistant if we are using one, and we may not be able to cure uh, tuberculosis. Prophylactic antimicrobial treatment, we said this involves administering antibiotics to prevent infections in individuals that are at high risk. Is commonly employed in specific surgical procedures to reduce the risk of post-operative infections. Also in patients with low blood count, I mean neutropenia, okay, low white blood cell count. These are patients with neutropenia who are highly susceptible to bacterial infections because the immune system is low. And also in individuals with recurrent urinary tract infections to prevent the recurrence, and in patients with risk of bacterial endocarditis, such as those with prosthetic heart valves or congenital heart disease. Prophylactic antibiotics can significantly reduce the incidence of infections and also improve the patient outcomes. We look at misuse of antibiotics. We say antibiotics are often misused, leading to adverse consequences such as the resistance and also treatment failure. Common misuse includes prescribing antibiotics for viral infection. This is one of the mistakes most of us do, especially somebody coming with a complaint of cough and I mean flu, for example. Flu is a viral infection. Why do you give antibiotics? This is really total misuse of antibiotics. And all this you need to use your clinical judgment before you can prescribe for some antibiotic. Where antibiotics are ineffective and unnecessary, treating fever for an of unknown origin with a proper diagnostic evaluation, initiating antibiotic therapy without bacteriological confirmation. This is what already I said before, especially the empiric treatment, okay? And neglecting appropriate surgical drainage, infections requiring surgical intervention. These misses contribute to the emergence and spread of antibiotic resistance and posing a significant threat to public health, as we said before. With this, we have come to the end of this lecture. Thank you so much and see you